When you choose a treatment for an older patient, it's very, very important to consider that patient's life, their frailty, and their side effect profile. And so this patient has been on probably a relatively low dose of lenalidomide, so it would be possible to increase the dose of that in the first instance and expect to get 6 to 8 months better disease control. So that's one option. You could swap to a drug with a different mode of action, and so adding in a proteasome inhibitor would be expected to work. And depending on the rate of progression, and this is an indolent progression, you could add in an oral proteasome inhibitor like ixazomib. If the disease was more explosive, then using the most effective proteasome inhibitor would be the best strategy, and using Kyprolis, carfilzomib. The other thing that you could do now would be to add daratumumab into the regimen that they're on. What you really don't want to do is beat up somebody of that age, because what you're trying to do is give them good quality of life as well as duration of life. So you should always enter into a discussion with the patient and really harmonize your therapeutic choice with what they want. And sometimes they want to come to hospital for injections because they get sort of companionship from nurses and the people in the hospital. Sometimes they want to be at home. They live 100 miles away and want to get on doing gardening. And so it becomes very clinical, the therapeutic choice. It's difficult to recommend any specific regimen for this sort of indolent type of progression, and I'll take any of the options I outlined based on discussion with the patient. There are some clear important things though. You shouldn't aim for the maximum dose in an older patient. It's important to choose a dose that they tolerate, because they get the benefit by being on it for a prolonged time. And if you maximize the dose and they only stay on it for 3 months, they can't possibly benefit from it. There is also important lessons about doublets versus triplets, and an effective triplet in this age group is well tolerated, and even though they're older, aiming for a triplet is probably a better strategy than just a doublet. So you have a whole variety of clinical options in this setting.
In a patient as was presented here, we're going to consider everything. We'll consider the biology of the disease, including the genetic factors, which we mentioned previously. We'll consider comorbidities. We'll consider also tolerance to prior therapy and patient wishes, and try to incorporate all of that information together. One thing we might do in 2017, which we would have not done 3 years ago, is for someone who has a T1114, we actually have been using off-label venetoclax in these patients. Venetoclax turns out to have some very interesting activity in patients who have a more lymphoid morphology. They are enriched among those that have the 1114. So we actually have done that in our practice quite successfully. And you know, if someone who's 81, you would be able to do that. That could be an option to be considered. Now, traditionally, this is reserved for further down the line once a person has exhausted therapy. So normally you would think, you know, this person could get a carfilzomib-based combination, or it could get daratumumab in combination, perhaps with pomalidomide. But I would say the wild card there would be that a lot of people are starting to consider the use of venetoclax in situations like this.
So in this patient who now is older, receives standard lenalidomide and dexamethasone as her primary therapy, and then lenalidomide maintenance, and now is relapsed, this person, there's a few things that we need to consider when we're choosing her next therapy. First is the drug dose of lenalidomide at maintenance. I would say if that she was on 10 milligrams of lenalidomide maintenance, then I probably would not use lenalidomide as my next therapy. I would consider her refractory to lenalidomide. Again, we said earlier that I like to do an IMiD-based therapy, and then when they relapse, I would choose a proteasome inhibitor-based therapy. For this woman with some renal insufficiency, I think a great option for therapy would be bortezomib, cyclophosphamide, and dexamethasone, or VCD. I think that's a great regimen at relapse. She also would be a candidate for oral pomalidomide if we were looking for an oral regimen. And you know, of all the preferred regimens from the NCCNs, including daratumumab, Revlimid, dexamethasone, elotuzumab, Revlimid, dexamethasone, daratumumab, Velcade, dexamethasone, all of those are potential therapies for this patient, but I probably would go with either VCD or pomalidomide as the next therapy. In an older patient, you really need to consider supportive care measures. I think there's 4 supportive care measures that she needs. First, she needs bone health. And so for her bone health, she needs calcium and vitamin D. And if she hasn't had biphosphonates, I certainly would give her a year of biphosphonates at monthly dosing, or consider 2 years at every 3-month based dosing. That's my personal practice. The second thing is they need infectious disease prophylaxis. Anytime they're on a proteasome inhibitor or on any dexamethasone, shingles can recur, and the percentage, maybe 10% of patients may develop shingles if you don't put them on prophylaxis. So they need acyclovir for prophylaxis. The third thing is to improve their blood counts. So especially in a patient that has renal insufficiency, and she has baseline renal insufficiency, she may be anemic due to low EPO levels. And I would have no problems putting this patient on erythropoietin to try to stimulate the growth of her red cells and to try to keep her hemoglobin above 10. I think patients, especially 80-year-olds, feel much better if their hemoglobin is between 10 and 12 rather than less than 10. And lastly, if I am going to put them on an IMiD-based therapy, I do want to make sure that I'm preventing blood clots. There's a variety of strategies that can be used. Most commonly, I use aspirin alone as a single agent, but we can use Lovenox as prophylaxis. And there are some studies that are going to evaluate the 10A inhibitors or other next generation anticoagulants in this patient population, which I think would be a big success in these types of patients.